Good morning to all. At the outset, I would like to thank the organizing team of this conference for giving me the opportunity to present this topic. And I wish the conference a very successful event. So today we'll be talking on anesthesia delivery in acute ischemic stroke. So I'll be taking this topic through all these incidents, various pathophysiology, diagnostic aspects of this stroke, anesthetic implications, guidelines, and controversies. In this, I'm not discussing on the perioperative strokes which can happen in vascular or orthopedic surgeries or cardiac surgeries. Coming to the incident, as you look at the picture, this is where we stand. Our stroke incidence is similar to some of the African countries and South American countries, and including Canada. It's approximately around 120 to 150 persons per 1 lakh population. The important and relevant point which you should understand in this patient, our countries has a population of aging persons are increasing. As you look at this picture, as the age grows up, the incidence of stroke increases. So will be going through the pandemic of stroke in next 10 years or so. This slide is very important in the patient anesthesiologists who are managing the stroke, because of the comorbid conditions which they may present, which we have to tackle. So hypertension was more common, almost like 55%, diabetes, large vessel artery disease. Many of the patients may present with the untreated atrial fibrillations and high risk of tobacco use in various forms and carotid artery stenosis. So this will help in managing this patient, as we have very limited time to intervene these patients as anesthesiologists. When I talk about acute ischemic role and role of anesthesiologist, I talk about the large vessel disease. Large vessel occlusion means proximal carotid artery, carotid bifurcation, and the proximal anterior cerebral artery and the middle cerebral artery with bifurcation. We don't discuss on the small vessel disease, which is usually the domain of the neurologist, and we don't require anesthesia management in these kind of patients. A brief about pathophysiology of stroke in respect to anesthesiologist importance. There is arterial occlusion, as everybody is aware of. So there is a period of hypoperfusion depending upon the degree of collateralization and degree of block. As the perfusion comes down, there is a period of anaerobic glycolysis and increased oxygen extraction by which the tissue try to survive. If it fails, then there is an infarct which is happening. If there is arterial occlusion, the usually standard imaging technique is angiography, either CT or MR angiography or DSA. For hypoperfusion, we use the modified MR sequences like perfusion weighted images. For the metabolism, we use MR spectroscopy, where we can measure the pH or lactate levels, and we can use radiolabel PET scans using fluomesanil or oxygen extraction can be measured by using the oxygen radio tag water. This is where the dark tissue is the infarcted tissue surrounded by a light blue color, which is a higher oxygen extraction, whereas this red color shows the normal oxygen extraction, this green and red. So this is how the area of oxygen, high oxygen extraction can be easily identified. So these images we should be familiar, we should be able to interpret. This is an MR image, which is called the diffusion weighted image. Diffusion in period of acute stroke as early as 30 minutes, there is a restriction of water molecules movement, which happens in stroke because of the cellular swelling, and there is a compression of blood vessels and ischemia occurring. So this is called the diffusion restriction. So this is probably a T2 weighted image showing the infarct. This is a arterial spin labeling showing the delineating of the blood vessels of the brain. You can see on the left side, this is ICA, this MCA is seen well, whereas in the right side, there is a MCA occlusion which is seen. So this is very important to understand the pathophysiology. So whenever there is an infarct occurs, we use the diffusion weighted images in the MR. Suppose you are using MR, we see something called a core infarcted tissues, so which is marked in red color, where the blood flow is less than 12 ml per 100 grams per minute. Surrounded by the core infarcted tissue, we have something called the gray zones or the penumbral zones. So penumbra, we have a blood supply of between 14 to 20 ml per 100 gram per minute. Surrounded by the penumbral region, which is called the hyperperfused areas, where the cerebral blood flow is between 20 to 25 ml per 100 gram per minute. In the normal tissue, the blood supply is usually more than 25 ml per 100 gram per minute for the survival of the tissues. So when you know that how much amount of salvageable tissue, you go for the diffusion perfusion mismatch, or is a PWI minus DWI. So you have the mismatch which will be automatically calculated by the radiologist. And if the area is more than 2.4 times between the core infarct and the penumbra, then we can take this patient for the thrombolytic. If there is matching, then the patient may not benefit with all this intervention which we are going to do. So there is a pictorial representation. It's the core tissue and the ischemic penumbra. So what we are more interested is to immediately recanalize these patients to improve the blood supply to the penumbra and remove the occlusion. Then from the anesthesiologist point of view, we have to improve the collateral circulations by manipulating the blood pressure and improve the oxygen delivery so that the ischemic tissue receives the oxygen conversion from anaerobic to aerobic metabolism. So how do you diagnose? So this is based upon the mnemonic B fast. You use the balance, loss of balance, eye, visual disturbance, facial deviation, weakness of the arms or legs, and alteration in the speech. And the most important, what we see is the time interval from the onset of symptoms. So when the patient presents to the emergency department, we take for the plain non-contrast CT scans. We rule out hemorrhage. If there is hemorrhage, we manage differently. If the patient is having infarct, we manage based upon the protocol which we're going to discuss in the future. So what we see is, what we do a scoring system called the aspect score. So we take the MCA, territory of the MCA. We divide into 10 segments based on M1, M2, M3. And this is where basal ganglia are located. These are caudate nucleus, lentiform, internal capsule, and the insula. So this is the one segment, and one segment above this we have the M4, M5, M6, a total of 10. So each segment which is infarcted, a score of 1 is detected. As you can see in this, a patient with a large infarct, usually around, you can see 2. You can see a little part of M3 is and M5 is awarded. Rest of the other areas are infarcted. This is how we calculate. Anything more than 6, we go for intervention procedures. If the time interval is less than 4.5 hours, we take glucose measurements, rule out hypoglycemia as a cause for stroke. If it is not there, then we go for the non-contrast CT, and if there is aspect score is more than 6, then we go for a CT angio to identify any large vessel occlusion. If CT is contraindicated or difficult, then we go for the MR imaging. So if the time interval is anywhere between 4.5 to 12 hours, sometimes now the time interval has extended even up to 24 hours, or if the patient is having wake-up stroke and the CT is normal, we go for the MRI diffusion perfusion weighted images to identify the ischemic penumbra and do the angiogram for identifying the large vessel occlusion. If there is large vessel occlusion, then we go for the mechanical thrombectomy. If the patient comes outside the time window or poor aspect score of less than 6, then we admit the patient in the ICU, watch for the progression of the stroke. If there is more than 50% of the hemisphere is infarcted, that's what we call the malignant MCA infarct, then we take the patient for decompressive craniectomy. So indication for endovascular therapy, thrombectomy has been extending. Initially, it was beyond the thrombolytic window, or if there is a large vessel occlusion, down it has even extended up to 16 hours or even wake-up strokes, which were not previously indicated in these patients. So anesthesiologists may be involved in IV thrombolysis. As you, one of the surveys told, only 40% of the time there is a neuroanesthesiologist available during mechanical thrombectomy or acute stroke care in US and Europe. 60% of the time, the general anesthetists manage these patients. So it is very important for all the anesthesiologists to be aware of the various procedures and the problems which they can encounter in managing these kind of patients. You go for the IV thrombolysis, then mechanical thrombectomy. How do you assess the time and then workflow, and what are the different controversies which has come in the management of these patients. So this is a video presentation showing how the mechanical thrombectomy is done. This is using solitaire device. So you can look at there is a thrombus occluding the MCA, this is MCA bifurcation, this is the ICA. So the interventionist first pass the guide wire over which a catheter is threaded beyond the thrombus, as you can see here. Then the guide wire will be removed and a stent retrieval will be passed through it. Here we are using the solitaire. It consists of an expandable spring-like structure, as you can see here. When the interventionist expands the spring, the thrombus gets entangled and then it is removed slowly. See, it is being expanded. The thrombus get entangled within the spring of the device. And the thrombus is removed. So anesthesiology should be very familiar and important with this picture. So patients come to the emergency department assessed by a radiologist or critical care person or anesthesiologist. They see the GCS score, NIH's National Institute of Health stroke score, and take a two wide bore IV lines and take the samples for biochemical analysis. Then patient is shifted for CT. If the CT is normal and is a diagnosis of stroke is confirmed, we start with IV thrombolysis. If it is a large vessel occlusion, we prepare the radiology suite. And then if you look at the time to shift, it should be less than 20 minutes from the ICU to the radiology suite. And we have 10-minute interval is given to the neuroradiologist or any radiologist to prepare the patient for mechanical thrombectomy to provide some form of anesthesia if the anesthesia is required in these patients. So we have a very limited time. If you prolong the time, then the risk of recanalization, the chances of recanalization comes down. So various anesthetic challenges. It's an emergency procedure. It comes in midnight, odd times, wake up stroke, early mornings. So anesthetists should be fully aware of the time period. Then patients are poorly prepared or evaluated because we don't have time to evaluate completely. Unlike other procedures, patient may have multiple and severe comorbidities. So acute stroke can have an impact on multiple organs, especially we are worried is the cardiovascular system as well as the pulmonary systems. Patient may be on various drugs, patient may be having hypertension, cardiac problems. We should be having limited time to understand what are the drugs patient taking. Many times the history may not be available. We should be anticipate this. The patient may have a lot of drugs might be taking and manage accordingly. Another most important thing is anesthesia is done outside the operating room. So you may not get the help, you may not have the same facility what you get in the operation theater. And patient may need to be transported to various places from emergency department to CT, MRI, and DSA. So especially sick patient, it may be very difficult to transport without adequate support. So in the radiology suite, we should be worried about the contrast allergy, which patient may have, may not have the history of the allergy. So when the patient is in radiology suite, we have to choose between general anesthesia or monitored anesthesia or conscious sedation or local anesthesia. So this will give some idea about how to choose if the patient has got low GCS, unconscious or uncooperative, and if the ACI status is poor, or patient is having large MCA stroke or posterior circulation stroke where the respiration can be compromised, and if the patient has got a systemic complication like comorbid conditions, then airway difficulty anticipated or severe hypoxia. If the saturation is less than 85, you may probably have to go for intubation and do a general anesthesia. If all these things are not there, if the patient is conscious, cooperative, well preserved young patients, then you can go for either conscious sedation or local anesthesia. If you look at the chart, which has come very early in 2010, there is a survey done among the US neuroanesthesiologists and anesthesiologists on the choice of anesthesia for mechanical thrombectomy. General anesthesia was preferred both by anesthesiologists as well as the neurointerventionists, is more than 50% of the time, and followed by conscious sedation. So monitored anesthesia care and conscious sedation is almost more or less similar. Local anesthesia is preferred least because many times during the procedure, there is risk of prolonged time. They can develop complications like bleed, vessel wall injury. The neuroradiologist wants the patient to be totally immobile when the intervention is happening. So the advantage and disadvantage of general anesthesia versus conscious sedation, it produces total immobility of the patient and decrease the procedure time. So intervention can be done very smoothly and limits the risk of aspiration. The risk of aspiration is always high in these patients who are having altered sensorium and altered neurological problems. Among the disadvantages, we require a lot of workforce. It's outside the operating room, and there is a time delay, and then anesthesiologists are put under a lot of stress without a proper history or medical conditions and clinical evaluation of the patient. We may have to manage these patients. Risk of anesthesia is always there, and always there can be changes in hemodynamic parameters, which is higher in general anesthesia compared to the conscious sedation. Conscious sedation, monitoring of neurological deficits is good. There is no delayed recovery which happens usually in the general anesthesia. Whereas disadvantages, the procedure time is increased because patient may become uncooperative. Then emergency conversion to GA is always tricky and difficult, especially when the patient is already heparin is being injected. At the time you do the airway intervention, risk of endotracheal bleed, airway bleed can be very high in these patients. And the risk of aspiration for emergency intubation is also very high in these patients. A survey which has come very recently in June 2021 among the anesthesiologists practice in endovascular thrombectomy in various centers in the US and Europe. If you look at that, US use 50% endotracheal intubation with GA, whereas 49% told that they will follow the MAC protocol. Whereas in Europe, if you look at endotracheal intubation is preferred only in 34%, whereas 66% use MAC protocol. And most important thing is the dedicated neuroanesthesia teams are available only in 35% of the areas, whereas 65% is managed by general anesthesia team. Hence, it is very important for people who are not even neuroanesthesiologists to understand acute ischemic stroke and how to manage these patients. Endotracheal tube is more preferred because of the airway issues in these kind of patients, and less use of supraglottic airway both in the Europe and the US. So in the same survey, what type of anesthetic management which they employ, if you look at that, majority of the people use either propofol or etomidate, and most of them they use propofol as the induction agent of choice. We also use either propofol or etomidate based upon the comorbid condition. If the patient is unstable, we use etomidate. Otherwise, we use propofol for induction agents. We use atracurium or vecuronium for producing muscle relaxant, and we use fentanyl. So many other centers abroad, they use propofol with the remifentanil combinations. Among the maintenance, there is wide variation in the practice. TIVA-based techniques is mostly used in many centers across Europe. As you look at that, inhalation anesthetic agents is more commonly used in the United States. Volatile anesthetic agents is supposed to be have a more favorable outcome because it produces cerebral vasodilatation, whereas TIVA produces vasoconstriction. So there is always a concern which one is better, but still there is no randomized controlled trial to say which one is better. So volatile anesthetic agents, again, the chance of recovery is much faster and better, so neurological outcome can be measured at the end of the procedure. So this is an article which tried to do a meta-analysis of different type of anesthesia, which one is better, GA or conscious sedation, endovascular thrombectomy. What they found is good functional recovery was found more with the general anesthesia group compared to the conscious sedation groups, whereas there was no mortality difference between the general anesthesia and conscious sedation. Earlier retrospective studies showed that general anesthesia is associated with the poor outcome and increased mortality in stroke, which was refuted by new articles, more and more studies which are coming. There is one more recent article which has come regarding the outcome of the patients, neurological outcome, comparing general anesthesia with monitored anesthesia care. This is a modified ranking scale. So lesser the scale is better the outcome. So we can see 0, 1, and 2 is considered to be better outcome. 5 and 6 included disability and death. So if you look at that comparison in patients who had general anesthesia but if not successfully reperfused, as well as those who had successful reperfusion, general anesthesia had a better outcome. You can see in this picture, GA with the reperfusion, total reperfusion. They had a better patient with the modified Rankin scale or below 2, whereas if you look at that conscious sedation, those who are completely reperfused, more patients were in disability or death compared to general anesthesia. So the mortality, there is not much difference, and the neurologically there is better outcome with general anesthesia. So I feel that in future more and more people will use general anesthesia compared to conscious sedation. So concern for anesthesiologists, two important concerns. One is oxygen delivery, which I had informed already, and second is the blood pressure management. Coming to the oxygen delivery, this is a study which has come in July 2021. It shows what is the role of high oxygen or low oxygen and outcome of acute ischemic stroke. We are compared between general anesthesia and monitored anesthesia care. The median level of SpO2 in patients with general anesthesia was higher compared to monitored anesthesia care. As you can see, it's around almost marginal difference is there. The study evaluated the different SpO2 and the mortality in these patients. What they actually found is, if you look at this graph, it's a U-shaped graph. Higher the oxygen saturation of SpO2 more than 98, the mortality started increasing both groups, GA as well as conscious sedation. Again, if you look at that, below 94%, the mortality is higher. So the article describes that you have to maintain the SpO2 between 94 to 96%. Why high oxygen is dangerous? Because oxygen can increase the free radical formation. It can worsen the reperfusion injuries. Hence, the optimum SpO2 which is targeted usually between 94 to 96, not higher or lower in this acute ischemic stroke. Third important point which anesthesiologists should be taking care is the blood pressure management. As you know that this is the autoregulatory curve. Many of these patients can have a comorbid condition like hypertension. Autoregulation usually shifted to right. So the lower limit of autoregulation is the one which we are more important. If there is autoregulation is impaired, as most of the articles show, as early as 30 minutes, and autoregulation takes few weeks, it took 2 to 4 weeks to return to the normal in this acute ischemic stroke. Maintenance of appropriate blood pressure is very crucial in reducing the infarct volume. Similar to the oxygen curve, there is again a U-shaped curve has been described in the outcome with the blood pressure comparison. As you look at, this is the systolic blood pressure. As the blood pressure goes more than 180 systolic pressure, the mortality increases. Again, similarly, if it is less than 120 millimeters of mercury, again there is a mortality. So anywhere between 140 to 160 should be a good target to maintain the functional outcome of these patients. So when the another important thing which we should remember is the ischemia reperfusion injury when you talk about blood pressure in acute ischemic stroke. When they try to recanalize, three things can happen. Following recanalization, there can be successful reperfusion. Patient becomes better. All these ischemic tissue will be reperfused and the function returns to normal. Second is there can be failed recanalization. There is no reflow. And third is there is successful recanalization, but the injury increases. That is called the ischemia reperfusion. Two types of injury has been noted. As the top one, you see that this is a patient who had a small infarct. Following reperfusion, the infarct size has gone up. In the second picture, there is a reperfusion injury in the form of bleed. The dark tissue which is seen is actually the bleed which is seen. So either it can be worsening of the infarct or can be a hemorrhagic transformation. These are the two damage which can happen following recanalization. So this same survey which I had described, what is the how the blood pressure is being managed during endovascular thrombectomy is the same survey shows. So majority, almost one third of the people maintain the systolic blood pressure above a threshold of 140 to 180 millimeters of mercury, and one third of the people maintain within 20% of the baseline. So actually, what the guideline says, blood pressure should be maintained between 140 to 160 millimeters of mercury. Various guidelines from the anesthesiology societies as well as American Heart Journals. So this survey found that only 30% of the people actually maintain as per the guidelines. Almost 70% do not follow the guidelines. So it is very important to understand how the blood pressure needs to be managed in acute ischemic stroke. So in the preoperative period, for patient with intravenous thrombolysis plan, you have to reduce the blood pressure to 185 to 110. If it is more than 220 by 110, it's usually contraindicated to do IV thrombolysis. The patient who is a candidate for endovascular thrombectomy, you have to again reduce to 185 by 105. Diastolic should be 105. This is where we are more bothered about the intraoperative period. In patients who are undergoing mechanical thrombectomy, you have to try to maintain within the baseline, as I already informed you in the graph. So target should be probably between 140 to 160 millimeters of mercury. So various anesthesiology articles recommend maintain a mean arterial pressure of more than 70 to or 90, around 70 to 90 is a target to maintain the cerebral perfusion pressure. Compared to the head injury brain trauma foundation, the MAP is slightly higher because of the shift of autoregulation toward the right side. So post-procedure, again, blood pressure should be reduced to prevent the ischemia reperfusion happening. So target blood pressure advice is less than 150 millimeters systolic for 24 hours. And if it is more than 180 millimeters of mercury, aggressive reduction should be done to achieve below 150 millimeters of mercury. Anesthetic goals: maintain euvolemia, try to avoid hypotension, maintain the blood sugar between 140 to 180 milligrams %. Ventilation, you have to secure the airway, especially if there is a airway compromise, difficult intubation occurs. Maintain the target SpO2 of 94 to 95 or 96. Employ your lung protective ventilations. Maintain the normocarbia. Both hypo and hypercarbia can worsen the outcomes. Plan for early awakening for neurological testing. In the intraoperative period, vigilance should be ensured for occurrence of complications and prevention management, and targets blood pressure and coagulation management also should be there. This patient may be on aspirin, they may on warfarin, they may be given heparin during the perioperative period. So lot of drugs are being multiple drugs are being usually given to these patients for maintaining the anticoagulation to prevent the recurrence of stroke. So the risk of bleeding is quite high, especially when you do airway intervention in patient, especially emergency airway intervention or during conversion. The risk of oral airway injury can cause severe bleeding, or endotracheal bleeding can also happen in these patients if you are not providing a smoke induction. Choice of anesthetic techniques and drugs is per the choice of the anesthetist. Coming to anesthesia, another important core area in acute ischemic stroke is the decompressive craniectomy. Is the patient present with malignant MCA stroke at the time of admission or any time in the hospital stay? That means more than 50% of the hemisphere is infarcted. Then you may have to take for a patient for decompressive craniectomy to reduce the ICP and to improve the survival. Again, for posterior circulation stroke, the volume is not clearly mentioned. If there is a compression of cerebellar hemispheres, then you may have to take the patient for decompressive craniectomy of the posterior fossa. The main advantage of decompressive craniectomy is it immediately reduces the intracranial pressure to the lower level so that there is improved survival and better outcomes. Then again, the various risks and challenges for anesthesiologists during decompressive craniectomy includes bleeding, comorbid conditions. Again, there is a raised intracranial pressure, impending herniation, which cannot be treated with the routine use of our drugs, and a lot of hemodynamic instability because of impending herniation. So intubation, again with propofol or etomidate we use, Maintenance, you usually use TIVA. We don't use inhalation agent, unlike in patient on radiological scene. Incidence of difficult intubation and the patient who are recurring rapid sequence intubation is also very high because majority of the patient may have gastroparesis. They may be on rice tube. So we have to be planned for a kind of rapid sequence intubations. Most important thing is the patient, as already informed, the patient can have a lot of drugs, especially antiplatelet drugs, heparin or warfarin. There can be risk of perioperative bleeding severely. So you have to use appropriate testing for coagulation management as well as use of blood and blood products for management of these issues. So we have to initiate ICP control measures, use of osmotic diuretics, mild to moderate hyperventilation, which is contraindicated in acute stroke. May have to employ these to prevent the brain bulge till the dura is open, ensure hemodynamic stability, glucose, and we try to avoid inhalation agents and nitrous oxide. Outcomes are better if surgery is done as early as 48 hours. Delaying more than 96 hours does not improve the outcome of mortality. Coming to the last, the role of anesthesiologist is very important in acute stroke management. As you see in this picture, they are an important part of a team in the emergency room along with the emergency department, neurologist in assessment of the patients presenting for the acute ischemic stroke as well as in the delivery of intravenous thrombolysis. The radiologists, they are a very important part along with the neurointerventionists in managing these patients to provide anesthesia cover in the operation theater for decompressive craniectomies. Also, it's very important. Um, it's a critical person in managing this patient in the operation theater. Again, post-operatively and post-intervention as well as in the post-operative period, anesthesiologist forms an important part in the post-operative mechanical ventilation, shifting the patients to various neuroradiological procedures if you need a tracheostomy or managing weaning and rehabilitating these patients. So anesthesiologist is very vital in the management of acute stroke. Thank you very much for giving the opportunity